Diabetic polyneuropathy. This is common finding in diabetics over 50 years of age. It appears clinically in two forms: Distill symmetrical polyneuropathy and mononeuropathy multiplex. Distal symmetrical polyneuropathy. This is the most common type exhibited by patients and its clinical features include sphincter weakness, numbness and tingling in the lower limbs, which is worse at night. Trophic changes are seen in the distal areas of skin. Ulcers may be multiple and joints. There is usually areflexia of the tendoachilles reflex and mild muscle weakness. The resultant weakness and sensory loss leads to an ataxic gait. The symptoms mimic Tapes dorsalis, but evidence of raised blood sugar provides the differential diagnosis. Mononeuropathy multiplex. The form affects older patients who have mild or undiagnosed diabetic condition. It usually involves nerve trunks supplying the pelvic and upper leg muscles. The presenting symptoms are frequently a complaint of pain in the lumbar or hip region, which is more severe at night. The quality of pain is described as sharp and lancinating. There is also muscle weakness and atrophy in the affected group. The deep and superficial sensation is variable in involvement and may only be mildly affected. There are, however, usually sphincter disturbances and urinary incontinence may become a problem. Pathology. Changes in the motor end plate in the form of expansion of the terminal ending are thought to precede the segmental demyelination of peripheral nerves. It is thought that the metabolic activity of the Schwann cell is altered by the disease process, although a causal agent may be ischemic changes secondary to the disease which occurs in the vasa nervorum. Medical management. The treatment of both forms of diabetic neuropathy includes the stabilization of the diabetic condition, the inclusion of vitamin supplements to the diet, the management of pain, physiotherapy. The patients with diabetic neuropathy often presents with other problems such as osteoarthritis of hip or knee not associated with a diabetic condition. The aims of treatment are to restore the normal range of movement, increase muscle strength or endurance, improve balance in sitting and standing, teach the patient a safe walking pattern with aids if necessary, teach skin and joint care if there is sensory loss, advice on the fitting and use of orthosis, advice on alteration or best use of the patient's home environment, help the patient achieve a satisfactory lifestyle.